Hi, everyone. Welcome to our Monty Hart lecture series. It's a great pleasure to have today with us Dr. Franz Messerli. So Dr. Messerli earned his medical degree from the University of Bern Medical School in Switzerland, and then he completed his postgraduate training in internal medicine and cardiology at the University of Bern. This was followed by a research fellowship at the Clinical Research Institute in Montreal, Canada, and then he continued his training for many years as a clinical research, as a director of clinical research after finishing his training at the Ochsner Medical Institution, where he became a clinical professor of medicine at Tulane University School of Medicine in New Orleans. He also served at this time on the Cardiorenal Advisory Committee for the FDA, and he has been very involved in research. He has over 900 publications. He has been a member of many editorial boards, including JACC, European Heart Journal, Circulation, Hypertension, American Journal of Cardiology. And some of his publications have been very highly cited, and he has been first author on several papers in the New England Journal of Medicine, Lancet, and JAMA. So for these scientific achievements, Dr. Messerli has received several awards, and among them a honoris causa doctorate from the university in Krakow, Poland, and the Alberto Sanchetti Life Achievement Award of the European Society of Hypertension. It's a real great honor to have you today. He will be speaking about is blood pressure an adequate surrogate endpoint. I've seen your lectures before. They are extremely entertaining and full of amazing things that we always think we understand about hypertension, but they are way more complex. So thank you again for taking the time, and looking forward to your lecture.
Thanks so much, Leandro. Delighted to be back at Montefiore. I was there probably about 12 years ago for grand rounds. Now, by definition, hypertension is simply a hemodynamic disorder. That's a given. However, when your systolic blood pressure is above 180, hypertension becomes an emergency, and the concomitant considerations are stroke, MI, etc. When it's between 160 and 180, hypertension is a disease with target organ damage, LVH, coronary artery disease, etc. When it's between 140 and 160, it's simply a risk factor, and you have to consider the associated risk factors such as hyperlipidemia, obesity, etc. And finally, when it's below 140, it is a marker associated very often with an unhealthy lifestyle, inactivity, smoking, junk food, alcohol, etc. Now, having defined hypertension, allow me to start with a mystery case. This is a gentleman who in the year 1935 was normotensive, 140/70. In the following years, mild hypertension, 1941, blood pressure 170/105. No blood pressure between 41 and 44, but 1944, quite severe hypertension with 240/140 in the fall. Finally, April 1945, a blood pressure of about 300 systolic and 190 diastolic was recorded. Patient we're discussing right here is Franklin D. Roosevelt, who you see sitting between Winston Churchill and Joseph Stalin. As you recognize, this is a picture of the Yalta Conference. I'd like to remind you that right here at Yalta, blood pressure, FDR's blood pressure was in that 240/140 range. The rest is history. This is the statement of his personal physician. It came out of the clear sky. Well, in all fairness, McIntyre was an ear, nose, and throat physician. He didn't know much about hypertension. But as you can see, Roosevelt was still smoking with a blood pressure of 240/140. So we have Roosevelt, hypertension, died at 63 of a stroke, and of course, smoking. We have Stalin, hypertension, died at 75 of a stroke, and of course, smoking. And here, Churchill, hypertension, died at age 91 of a stroke, and of course is smoking as well. So this series of cases very neatly illustrates the dictum of Sir George Pickering: stroke, regardless whether it's ischemic or hemorrhagic, is the most devastating complication of hypertensive cardiovascular disease. And if I ask you right now, if you had to wake up tomorrow morning and you had to have either a stroke or a heart attack, who would take a stroke? Raise your hand. And whenever I ask that question, I never see a hand go up in any audience, whether it's cardiology or general and internal medicine. So we have the stroke belt in the US. This is where strokes do happen, as you can see here. And allow me to be very simplistic here. This is a paper that came out about 10 years ago. And what it shows is very simple. It shows what you learned in medical school, namely that when you go from normotensive to being to stage 2 hypertension, your stroke rate goes up about threefold. As I said, you learned that in medical school or in kindergarten, but what you did not learn there is that when you are perfectly normotensive, your blood pressure being below 120 systolic, yet you are on 3 antihypertensive drugs, then your risk of a stroke is actually higher than having stage 2 hypertension. Okay, let me emphasize this. Clearly showing blood pressure is below 120, lowered by 3 antihypertensive medications, yet the risk of having a stroke is higher than having stage 2 hypertension. So maintaining the normotensive status solely through pharmacological treatment failed to return the risk level similar to normotensive individuals. Even with successful treatment, there is a substantial residual risk. Obviously, stroke is below, but risk remains that of untreated stage 2. So to make that very clear, as you go from pre-hypertension or normotension to stage 2 hypertension, your risk goes up of stroke, heart attack, and death. As you go back, you hope that this risk will go down as you give antihypertensive medicine. But actually what happened is this, right? There's a distinct residual risk, and you cannot revert back to a normotensive state. Yes, you can lower the blood pressure to a normal millimeters of mercury, but obviously your risk is still distinctly elevated. There is a point of no return. And obviously, if your aorta looks like this, if your popliteal artery looks like this, then this is the picture of your arteries, right? This is how they are. And once they are there, you want to consider, this is how it starts here. This is, classic. This guy wants to play, obviously, and he finds no cronies here who help him. And this is how it ends. And it's not so surprising when you look at this that antihypertensive therapy looks like a Pyrrhic victory because the residual atherosclerotic damage remains despite being perfectly normotensive. And what's more, and I think that's very important, that's a very important slide from the Framingham Heart Study. When you look at predictable survival by blood pressure values, once you are 70 or so, systolic or diastolic blood pressure has practically no predictable value anymore. So when you're above 70, it doesn't really matter whether your blood pressure is 120, 130, 140, 150, according to the Framingham data. Yes, you can still lower the blood pressure, but no, blood pressure lowering will no longer reduce risk of stroke, heart attack. Antihypertensive blood medicine becomes merely blood pressure cosmetics. Okay, So let's take a patient here, 63 years old, blood pressure 148/86. And the question number one is, what is the blood pressure goal in this patient? So you can go actually here to Paul Welton, who was the chairman of the JNC, American Heart Association, 25 members. He will tell you it's 130/80. Or you can go to my good friend here of the European Society of Cardiology, 75,000 members, and he will tell you, Brian will tell you it's 140/90. Or you can go to Dr. Kwasem, American Association of Family Practitioners, and 250,000 members, and he will tell you it's 150/90. Given identical evidence, how come that the three panels of experts arrived at setting apart the definition of what are supposedly optimal on-treatment blood pressure level by as much as 20 millimeters of mercury in systolic pressure? And of course, are they of clinical significance? Well, you go back to the famous paper here of 1 million patients, and you can see here that actually Dr. Welton would be here, Brian would be here, and Dr. Kwasem would be here. So there is a distinct risk difference in stroke of the three blood pressure levels. 5% for the ACC/AHA guidelines, 8% for the European guidelines, and 14% for the ACP/AAFP guidelines. So the absolute stroke mortality risk is almost threefold higher for the on-treatment target in the American Family Practitioner guidelines than in the ACC/AHA guidelines. And then what do the guidelines advise regarding the initial medication? Well, here, Paul Welton, you give one drug, and it doesn't matter that much. I'll come back to that a little later. Here, Ryan Williams, 2 drugs at the same time. You start treatment with 2 drugs. And here, Dr. Crossan, no drug. So a family practitioner will not treat this patient at all if he or she acts according to the guidelines. So this is, as you can see, the appropriate treatment intensification for older adults with hypertension in the US was suboptimal over the past decade. When you go with the family practitioner guidelines, it actually still is. So there is a rift between those who preach, like I'm doing now, those who teach, and obviously those who treat. Now, that's not so surprising. That's almost a given. But I proposed here in Circulation a few years ago that the optimal systolic blood pressure to shoot for should be 100 plus half your age. 100 plus half your age, which means age 40, your systolic should be 120. Age 60, it should be around 130. Age 80, it should be around 140. Now, this sounds very good, and you're going to ask me, what is the evidence here? And horrible dictum, there's absolutely no evidence. This was just a entirely arbitrary thought that I had. It nevertheless made it into Circulation. So it's an evidence-based idea. And I think it's very useful, but again, there is no evidence of this. Okay, this is a patient who I saw shortly before I left New York and went back to Switzerland. And the patient was a retired CEO who measured his own blood pressure. And you can see here, when you look at his blood pressure, 180 in the morning, the next afternoon, 119. And here, 174 in the morning, in the afternoon, 126. Tremendous fluctuations in blood pressure. So he looked at this and decided that's probably not very good. And he called my office, made an appointment, and came by and showed me these blood pressures. It so happened that at that time, visit-to-visit variability was a paper on visit-to-visit variability of blood pressure was published in the Lancet. And what they actually showed, that is the higher the variability here in the deciles of the standard deviation, the higher the variability, the greater is your risk of a stroke. So it's not only the absolute risk, of course, the absolute height of the blood pressure has an impact on stroke, but it's also simply the variability. And what they also showed is very simply that CCBs were by far the best to keep variability low, followed by diuretic, and much less good are the ARBs, ACE inhibitors, PBs, and so on. So I told the patient very simply, look, what you are doing, just using a beta blocker now and then when you feel stressed, or a diuretic when you think you ate too much salt, is complete nonsense. You stop all management, self-management of blood pressure, and you very simply take an amlodipine 5 milligram every morning. And you take that amlodipine every morning, regardless of what your blood pressure is. You can still measure it if you want to, but just take it, okay, even if it's low. And he came back 2 months later with these blood pressure. Absolutely smooth, perfectly normal blood pressure levels. In fact, actually a little bit low occasionally. So I told him, you know, you can take just 2.5 milligrams of amlodipine. That will be sufficient. Obviously, very impressive, right? Smooth blood pressure control with regular medication, a CCB, half a tablet once a day. Much better. Variability is no longer an issue. And now, this is an N of 1. And as clinicians, we are always impressed by N of 1. This is another N of 1 here. Winnie Langley died August 2010, age 103, having smoked for more than 95 years, hypertension since 40, lung cancer at 87. N of 1. Obviously, there are always exceptions. So you want to make sure that when you all of a sudden see that blood pressure variability can be improved, that this is indeed important. And I just show you here one paper looking at the visit-to-visit variability of blood pressure and coronary heart disease, stroke, heart failure, and mortality. This is from the ALLHAT study. And it's absolutely clear when you look at the standard deviation of systolic blood pressure and the hazard ratio, obviously, the higher the standard deviation, the higher the variability, the greater is all-cause mortality. So variability is an important issue. Now, since we have talked about Winnie, what should her blood pressure be? Should it be below 120, as the SPRINT data teaches? Should it be below 130, as ACC guidelines, 140, ESH guidelines, or the AAFP guidelines, 150? Does it matter? Well, in all fairness, the oldest dose, there's one point I want to make here, a very simple point actually. When you look at the prevalence of dementia, it obviously increases from 50 to 100. And the relative risk of hypertension contributing to dementia is actually here in the 50s. Later on, it has practically no effect. But what has an effect is hypotension. The more hypotension you have later on, obviously, again, the greater is your risk of dementia. So in the oldest old antihypertensive therapy is completely evidence-free zone. And, you know, you can very simply say, it doesn't matter which one of these blood pressures you select, it probably should be below 180. That's a given. But even that, there's no evidence to it. Okay. Now, this is another patient here, 56-year-old, took naproxen for joint pain, gained 20 pounds, body mass index of 29, sitting blood pressure 162/94 in both arms. And my question to you is, you would initiate treatment with an ACE inhibitor, i.e. lisinopril, a CCB, amlodipine, a NARB, olmesartan, thiazide, hydrochlorothiazide, or the combination. Please pick your choice. I'll give you an answer in just a minute. Now, this happened to be a paper in the New England Journal that came out almost immediately after the AHA-ACC guidelines were published. So, and what it so happened that Dr. Taylor here was an author of these guidelines. She was one of the authors of the AHA guide. So what is happening here is that in the most important journal in the US, one of the authors of the guidelines is teaching us how to use the new guidelines. And Dr. Taylor suggested a thiazide diuretic or an ACE inhibitor is a reasonable first choice agent to prescribe with follow-up blood pressure electrolyte measurement in 3 to 4 weeks. When I read this, my jaw was dropping. I could not believe what I read there. Now, of course, I understand lisinopril is common. In 2019, there were 91,000 prescriptions of lisinopril in the US. So obviously, yeah, it's common. But number one, and we sent a letter to the New England Journal of Medicine, and arrogant as they are, they actually declined it and rejected it. So we published this in Hypertension. Since the patient's presenting blood pressure was 32/14 above the target of 130/80, why was the treatment not initiated with 2 drugs as the ACC-H guidelines recommend? As you can see here, they say clearly 20/10 above the target, so you need a combination. And how are we to expect practicing physicians to follow guidelines when their own authors demonstratively ignore them at the first possible opportunity? Number 2, and that's something that a lot of physicians don't know. Since the patient needed naproxen for joint pain, why was treatment initiated with a renin-angiotensin blocker, which has been documented to be, the antihypertensive efficacy has been documented to be abolished by NSAID. That's not a good choice. You need either a thiazide diuretic or a CCB. Number 3, since outcome efficacy and antihypertensive efficacy is equal for ACE inhibitors and ARBs, why was, as the author emphasized, the drug class with more adverse effects selected to initiate treatment? And this is still, I want to emphasize this is still a very common error. First of all, we have the cough, which is common in patients on ACE inhibitors. No big issue, it's a nuisance. But then we have actually angioedema. And this is again New England Journal of Medicine. This 75-year-old man was treated with captopril for more than 3 years before he had an angioedema. It doesn't happen the first day or the first week. It may happen after years of antihypertensive therapy. So we tried to estimate the incidence here to give you an idea. First week incidence it's rare, no question. 1 in 2,500 patients, subsequent incidence maybe in 1 in 500 patients per year. And among the life-threatening angioedemas, larynx, it's around 20%. Among life-threatening ones that are fatal, 1% or something like that. This is all estimate. But when you translate this into 30 million ACE inhibitors used in the US, or even more, you still have potentially fatal angioedemas of more than 1,000 per year. Now you're going to say, this is all estimate, but allow me to give you here a paper. A 63-year-old man running onto the front lawn, waving a white towel, pointing toward his throat, collapsing, attended by neighbors, transported to hospital emergency room. Tracheostomy was done to no avail, and pronounced dead shortly thereafter. Medical history revealed hypertension treated with enalapril for at least 8 months. This is 1 out of 7 cases coming from a coroner's office. These are the other 6, and you can see here duration of exposure: 5 months, 21 months, 8 months, 10 hours, chronic. And obviously here, all of them are African Americans. It's much more common in African Americans than it is in white people, but nevertheless, it does happen in white people as well. And what is important, these are 85 cases of angioedema with ACE inhibitors, median duration of ACE inhibitor therapy before 12 months. And what is actually astonishing, the median time between the first attack and ACE inhibitor withdrawal, another 12 months. So physicians do no longer connect. Patients go with angioedema to the emergency room and is not even asked, are you on an ACE inhibitor? And so he continues the medication. We did a meta-analysis a few years back here, as you can see here. Obviously, ARBs are not completely free of the risk of angioedema, but much less common than with ACE inhibitors. And then there's the question, are ACE inhibitors more efficacious antihypertensive agents than ARBs? There is the big question that was brought up years ago in the British Medical Journal, that the drugs may increase myocardial infarction. Complete nonsense. We looked at this, a head-to-head analysis in 7 trials. You can see here absolutely no difference in outcome. And this is actually a multinational cohort study, also published very recently, and I published this in Circulation here. You can see here again, when you look at ARBs and ACE inhibitors in terms of outcome, absolutely no difference. So why in the world are we still prescribing angiotensin-converting enzyme inhibitors? Absolutely no reason to do so, except, as Sir Francis Bacon says here, once you have adopted an opinion and so on, you do all things else to support and agree with it. And I hope that lisinopril, like some other drugs, will shortly join the antihypertensive drug list of mostly historical interest. And finally, the last point here about the article in the New England Journal of Medicine, thiazide diuretic, the guidelines actually specify that clostridone is preferred at that time, and obviously that should have been said by Dr. Taylor. Based on the available information, the patient could have been started on a low-dose combination of an ARB with a CCB, and the above 4 points would have become mute. There would have been little, if any, need for follow-up and electrolyte measurements in 3 to 4 weeks. Okay. Quick, short issue about beta blockers. Beta blockers are efficacious antihypertensive drugs. We know that. You can see here, this is a Cochrane meta-analysis, lowering blood pressure by 10/8 millimeters of mercury. And of course, heart rate goes down as well. Atenolol is an exceptionally efficacious antihypertensive drug. That's premise number 2. And you can see here, atenolol lowers blood pressure by 15 over 13 millimeters of mercury in another Cochrane meta-analysis. So atenolol was prescribed at one time, 2004, as one of the most common antihypertensive drugs, 44 million prescriptions per year. Premise number 3, beta blockers are useful for the treatment of hypertension. And premise number 4, atenolol is exceptionally useless for the treatment of hypertension. Well, this started all the way more than 25 years ago. Until proven otherwise, beta blockers should no longer be considered appropriate for first-line therapy in uncomplicated hypertension. Beta blockers should not remain first-line choice in the treatment of primary hypertension. Here, Lancet, and here also Lancet, when you look at atenolol versus placebo outcome study, you can see absolutely zero effect. So despite lowering blood pressure by 15 over 12 millimeters of mercury or so, there is no reduction in mortality whatsoever. And again, here, same systematic review, all-cause mortality, no effect of beta blockers. But when you look here, all antihypertensive drugs reduce stroke to some extent. But beta blocker, if anything, actually increase the risk compared to other agents by about 50%. So clearly, this is true. The first premises, premise 1, premise 2. When efficacy is defined by a decrease in millimeters of mercury. And this is true when efficacy is defined by a decrease in outcome, namely MI, stroke, or death. And you can see here physicians have learned it, that actually when you look at the prescriptions in the US over the past 25 years or so, atenolol is on the way out. Now, in conclusion, all of a sudden here in Europe, beta blockers as a group should again be included in the first choice armamentarium of available antihypertensive drugs. This just came out last year. And the European guidelines, you can see here a lot of authors who have helped to put this together. And I only hope that, the dictum is true here, that consensus means that lots of people say collectively what nobody believes individually, because obviously guidelines are based on consensus. But nevertheless, as you can see here, beta blockers are now in the European guidelines on the same level as CCBs, diuretics, ACE inhibitors, or ARBs. And the idea is that with beta blockers, you can kill 2 birds with 1 stone. You lower blood pressure, and you have a favorable effect in the post-MI patient. Sounds good, right? But remember, they are less effective in preventing stroke, considerably less effective. If anything, they actually increase stroke, as we just have seen. And we published this in Lancet last year, that is basically not acceptable because the post-MI patient is at the very high risk of stroke. He or she's blood pressure should not be treated with a beta blocker. So in the post-MI patient, you need 2 birds with 2 stones. You treat the blood pressure with a CCB, with an ARB, with a diuretic, and if needed, and we all know that beta blockers are no longer a sine qua non in the post-MI patient, but if needed, you could give a beta blocker, but independent of the blood pressure, not for treatment of blood pressure. So to relegate to an inferiority status, as previous guidelines have done, was based on the evidence in aggregate. No new evidence support the switch of beta blockers to first-line therapy, and we are concerned that this move might lead to widespread harm because of inferior stroke protection. And then we have the side effects. These are Tired of Life, painted by Ferdinand Holder, and this is how you feel when you are on a beta blocker. So this paper was published in JAMA by Harlan Krumholtz, who happened to be the new editor-in-chief of JACC. Conventional wisdom that beta blockers associated with depressive symptoms, fatigue, and sexual dysfunction is not supported by data from clinical trials. And you can see here, we looked at this same database because I couldn't believe it. And we looked at actually the number of patients who withdrew for active treatment control group in randomized placebo trial. And you can see here when you look at withdrawals, okay? And this here actually was just the association of symptoms. But when you look at withdrawals, for every stroke or heart attack prevented, 3 patients were made impotent by beta blockers. 8 experienced fatigue to the extent that they withdrew such therapy. And that, ladies and gentlemen, is hardly an acceptable risk-benefit ratio for a completely asymptomatic disease, such as mild essential hypertension. Which brings up Walter Mondale and Ronald Reagan here debating. This was one of the first television debates in 1984. It so happened that at that time, Mondale had high blood pressure, which was treated with 3 different drugs, a diuretic, hydralazine, and a beta blocker, atenolol. And what did Mr. Mondale do? He indicated that he did not take the atenolol before the debate because it seemed to make him less mentally agile. Now, ladies and gentlemen, when can a president afford to be less mentally agile? When should he take a beta blocker? When should he skip the beta blocker? Now, Mondale's physician tried to defend him and said, if good old Fritz is good old Pratt, it is good old Fritz and not the atenolol. Well, I'm not so sure about that. Obviously, Mondale said God has no place in politics. Apparently, God feels the same way about Mondale, as I was said by Bobo. And then there's Don McNeil of the New York Times. The drug metoprolol made me feel a bit dull-witted, but I could still walk and talk. And there's acute delirium induced by metoprolol. So this brings up Messerly's rule number 1. Presidents should not be on beta block. That's a simple rule. But, guideline, evidence or convenience. Should guidelines be evidence-based or convenience-based? And convenience for who? Patients, physicians, or big pharma? Beta blockers, there's no question, remain useful for selected indications, but not for therapy of hypertension. So, but there is some hope that you can do a twofer. You can actually kill 2 birds with 1 stone. That does happen. And that is possible in the case of a presidential candidate. He had an LDL of 134 and obviously had a coronary calcium score that was elevated, and Dr. Topol felt that we're talking about a 70-year-plus old man who is obese and does an exercise. And here we go. You can see still very active. And obviously, when you do a twofer, you kill 2 birds with 1 stone. You obviously have an effect on the erectile function, and you have an effect on coronary artery disease. So this brings me to Messerly's rule number 2. there are exceptions to rule number one. Okay, Leandro, how are we time-wise?
We're good. If we want to do a little bit more, it's good whenever you want to stop.
Okay, I can do, let me quickly make sure. Oh yeah, okay, this is simple. Minimum. This is a paper I never published 50 years ago. 25 patients with mild hypertension, randomized to either a low salt diet or clostridone. Okay, good dose of clostridone. Outcome, office blood pressure, urinary sodium, baseline or after follow-up of 3 months. And now low salt diet, that's a big issue. And, you know, I was a young doctor at that time, and I didn't know much about low salt. So every single patient had to go to the dietitian. They were all instructed by a dietitian. And then they came back 3 months later, and we looked at the outcome. And the outcome is very simple here. You can see here, low salt diet, the blood pressure did fall a little bit. With clothianidone, there was a significant drop in blood pressure. But what was the astonishing part, when you look at 24-hour urinary sodium, patients on the low salt diet had exactly the same 24-hour urinary sodium before and after the instruction and the 3 months. And the same, of course, holds true for clostridone. They were not instructed here. And obviously, as I said, this was rejected numerous times. Nobody was interested in this paper, but conclusions were instruction of a low salt diet by a dietitian has no effect on salt consumption or blood pressure, and clostridone does lower blood pressure. Which brings me to the question, what should be the initial step in antihypertensive therapy? Lifestyle modification, exercise, weight loss, or medication? Well, you can see here Paul Welton, he rhapsodizes about lifestyle, non-pharmacologic intervention, and there's obviously flaxseed, increased protein intake, fish oil, Mediterranean diets, garlic, dark chocolate, tea, coffee, biofeedback, etc., etc. Sounds very good. Allow me to give you a simple piece of advice, and that is the John Wayne approach. What do I mean by this? I mean very simply, shoot first and ask questions later. And this means once hypertension is identified, drug therapy is mandatory, lifestyle modification should be concomitant to the device and maybe complementary. And if a patient, and I've never seen that, if a patient returns with too low a blood pressure after lifestyle modification, drug therapy can be down-titrated or discontinued. So it is primarily medication and lifestyle modification. It's a good thing to tell the patient to do so, but compliance with this is in general not very good. So this is a painting by Juan Miró, hanging actually in Switzerland, in Lucerne. And this is a Rolex Oyster Perpetual. And this is, as most of you would recognize, Ernest Hemingway. What do they have in common? Well, they have in common the dictum that Hemingway said about the heart. He said simply, it's just a muscle. Only it is the main muscle. It works as perfectly as a Rolex Oyster Perpetual. Trouble is, you cannot send it to the Rolex representatives when it goes wrong. When it stops, you just don't know the time. You are dead. Thank you so much.
Thank you very much, Dr. Messerly. What an amazing lecture. I think we all learned a lot. So please put your questions in the QA if you have any, and we'll go through them. So I will start with a question, and we were briefly chatting about it first, about the ambulatory blood pressure monitors. So you mentioned the use in Switzerland confirming hypertension for 24 hours. So could you tell us a little bit more about how you use it for the diagnosis before you treat?
Yes, absolutely. That's a very important issue. When I was practicing in New York, I used 24-hour ambulatory blood pressure monitoring a lot. But it was a deficit proposition because, as you'll know, reimbursement is not very good. Now in Switzerland, it's fully reimbursed. So basically, before any patient is started on antihypertensive therapy, we do a 24-hour blood pressure recording. We do this also, for instance, in renal denervation, before renal denervation. And, very often you find white coat hypertension and similar issues. So it is an important diagnostic tool. But again, if it's not reimbursed, it's difficult to practice this.
Thank you very much. Yeah, hopefully the payers follow your advice with that and incorporate it. So Dr. Garcia, would you like to do the next question?
Well, first of all, I have to say I enjoy this so much. Not only I learned, but I was entertained to the point that I'm still trying to control myself from the joy. And my regards to Adrian, please. So first of all, I wanted to say that I do agree with you. Some presidents should be on beta blockers. I know at least a couple of them. But I wanted to talk to you about a patient who I saw recently. I was called by this businessman who, at age 88, is still very active, working 70 to 80 hours a week in his multiple businesses. And he was concerned because he has taken his blood pressure at home and it was elevated. So I went to his house. I checked his blood pressure 3 times. And I got systolic of 170, 180, and 150. And the gentleman is pretty healthy, other than he has Parkinson's. And on a prior occasion, he was started on a small dose of an ARB, and he developed orthostatic symptoms, so he could not tolerate. So before I initiated therapy or recommended anything, I say let's put an ambulatory pressure recording monitoring, which I don't use very often here in the States. You may know it's very difficult to get adequate reimbursement for them. But I did it in this particular case because I was worried about the orthostatic symptoms. To my surprise, the mean pressure that I got through the device was 128/70. With only 3 spikes during the day, where it reached numbers in the 160s and 170. It made me really question about how many patients I may have overtreated over the last 35 years in my career because of the numbers that I get in the office.
That's a very good point. And I think that's why really 24-hour ambulatory blood pressure is very, very helpful. This is exactly the phenomenon that we see all the time, that the blood pressure when the patient over a 24-hour period is practically normal, although the patients may occasionally have some spikes, there's some white coat hypertension, et cetera, et cetera. So a very important issue. And, we tried hard for years to get a decent reimbursement in the US, but it was very simply not possible. And that's a sad story in a way, because it's a very useful diagnostic tool. There was a good paper in the Lancet from Spain. I think it was last year in May or so. And it shows you that 24-hour ambulatory blood pressure is much closer related to morbidity and mortality, that is stroke, heart attack, and death, than is office blood pressure. So again, office blood pressure is very often misleading. You're absolutely right.
Thank you very much. We have a question from Rob Osfeld, our Director of Preventive Cardiology. He says, thank you for the wonderful talk. In regard to dietary sodium, What are your thoughts on the Gupta study reported at the AHA and published in JAMA, where low sodium diet, about 500 milligrams daily total sodium, lowers systolic blood pressure by about 8 millimeters of mercury, compared to a higher sodium diet that was about 2.2 milligrams added daily to the usual diet?
Very good question. I'll be delighted to give you a whole lecture on sodium, which I've done many times, because it's a very complex issue. No question that blood pressure is related to sodium, and that with a low sodium diet, you can lower blood pressure, and a high salt diet, you increase blood pressure. But what has not been conclusively shown is that the sodium manipulated, so to speak, the sodium manipulated blood pressure translate into outcome. That is entirely unclear, because there are some very good data showing that too low a sodium diet increases your risk of heart attack and stroke substantially. It's a distinct J-shaped curve, and this could well be, that sodium, too low a sodium diet is a direct risk factor of heart attack and stroke. So it's a complex issue, and I'll be happy to send you our own paper that was published recently in the European Heart Journal.
Thank you very much. So we have a few questions more. So from the fellows, they say, so if you had to pick one combo for treating hypertension, what combination would that be?
As I made the point for Dr. Taylor's write-up in the New England Journal, I would simply use an ARB and a CCB. I think that's by far the easiest combination. There are quite a few available in the US, and even in the elderly patient, you can very simply start on half a pill of whatever is available, whatever you have at hand. And that's usually very well tolerated, and you can escalate the dose, up titrate as you see fit.
Thank you very much. From Daniel Lorenzati, he said, thanks, I enjoyed the lecture very much. If you had to use beta blockers for blood pressure control, I know you are a little bit against it, but if you were going to use one, would your opinion change with nebivolol, for example, or Coreg?
Nebivolol, or for that purpose, labetalol and carvedilol are the vasodilating beta blockers. And they admittedly have a more patient-friendly hemodynamic profile and metabolic profile. They lower peripheral resistance, they maintain cardiac output, in contrast to the classic beta blockers. So they are, so to speak, my preferred beta blockers if I have to use them. But having said this, I want to make it very clear, there are no outcome studies, neither with nebivolol nor carvedilol, showing that their use reduces morbidity or mortality, as opposed to atenolol, where there are numerous outcome studies showing that it does not reduce morbidity and mortality.
I'm curious to why you didn't include labetalol in that group.
Yeah, labetalol is a useful agent for hypertensive emergencies. There it's still used. In pregnancy, it may be helpful, but it's not very well tolerated in general. The side effects are more pronounced than with carvedilol and nebivolol. That's the only reason I've not mentioned it.
What about clonidine? Do you ever use it, or should it ever be used?
I used to do some clonidine loading when I was on St. Luke's Roosevelt, but then the patient gets drowsy and falls asleep. I'm not so sure whether this is a good idea. There will be actually a review article in JACC in about 4 or 5 weeks from now on hypertensive emergencies, and I don't think we mentioned clonidine loading anymore. So no, clonidine we no longer use.
Okay, and now just to finish, a great question from Anna Bornik that we knew was coming. So is there any role for renal denervation?
That's a very hot question and a hot topic at the present time. I'm just writing an editorial. I don't want to give any secrets away. I make one point. There is a recent meta-analysis showing that after 2 months, 24-hour blood pressure falls by 3.6 millimeters of mercury. 3.6 millimeters of mercury with renal denervation. In about a third of patients, there is no effect or blood pressure increases. In the other 2/3, it obviously decreases some. So the question you have to answer is very simply, is 3.6 millimeters of mercury a result that justifies an invasive procedure, number one? And the question number two is, of course, there are no outcome data. We don't know whether these 3.6 millimeters of mercury fall in blood pressure reduce morbidity, mortality, heart attack, stroke, or death. So I'm very skeptical about renal denervation at the present time.
Okay. Thank you very much for the amazing lecture and for spending some time with us. And hopefully when you come to New York next time, we'll have you in person here.
I'll be happy to come out to Monte. Okay.
Take
Have
care.
a good afternoon. Thank you so much.